Okay. So again, welcome everyone. This is the first technical session in the Collective Learning Certificate 1 course. And this particular session is about the key stakeholders in supply chain. I believe almost all of you or most of you have been going through the first two modules. And in those modules, we have been talking about the key stakeholders in supply chain and how is supply chain governed in your countries. So this particular session, we will focus on those questions, and we will discuss on some key points related to governance, related to flow of products, money, and information, and a few additional things. So let's begin with looking at what is happening so far in this week. So this is Thursday. The course started on Monday. We had the first introduction classroom session on Tuesday, and since then I have been seeing a lot of action on the platform. All of you are going to the lessons, you are responding to the questions posed to you. You are also talking with each other, which is really amazing to see. So let's see what all is happening this week. So these are some snapshots from the platform itself. Here in this snapshot, I see participants responding to the question as to what is the most common term being used in their countries, for supply chain. And in the lessons as well, we talk about what is the most correct term to use. So I see it's quite different in different places. Some places it's called logistics and supply chain. Some are calling it health commodities supply chain, drug and medical supply management. Even two people from the same country are talking about two different terms. So this is one way to show that in the health sector, or sometimes even beyond, these terms are not very clear. And that's why one of the reasons why we begin the course by talking about these terms, because these are important things to understand, and sometimes we may confuse when we use different terms, and you have seen that people use these terms interchangeably. So supply chain is I would say, one of the most whole term to use here, at least for health, because here we are looking at both upstream and downstream operations. Now, when I talk about upstream, I mean operations which relates to quantifying what is the need, and then procuring those products. And then downstream is once those products are sourced or procured, they are sent to the required destination, which is the health facilities. So in the health sector, we have both these operations. There are some organizations who may do only procurement. So they would use this procurement term or sourcing term more often than not. There are some organizations who are more involved in downstream operations, and they would term themselves as logistics organizations, and sometimes organizations are on logistics or use supply chain. So it's a bit confusing. But as in the course, Andrea, can you please mute or participants, if you can mute yourself if you're not speaking? There is some echo from someone.
Can Frey, could you mute, please?
Okay, I've just muted him. Yeah. So this is just a brief point to note here, and I'm sure there are other terms as well, where it is a bit confusing and people use different terms to sometimes talk about the same thing. So moving on, there are other discussions that are happening this week, and one of it is, which is on the screen now, where all of you are discussing about the key challenges that your country's supply chain is facing right now. In the current scenario. And one of the points that Barbara has mentioned here, which I also responded to on the platform, was that sometimes, and I don't know, first of all, Barbara, what exactly you meant, because I'm not sure if I've read your response. But from my own experience, I've seen that people confuse between uh, having a system to collect and disseminate data and an electronic LMIS system. They think that an electronic LMIS system is something which is absolutely necessary to have a good data management system. Well, it's not. Data management has been done manually for thousands of years, and it has worked well in the history of humankind. So ELMIS is not really something which is absolutely required, but yes, it is a game changer in today's scenario where we want the data fast, we want the data more accurate. So yes, it is a game changer. But even before installing or having a ELMIS, what is more important is to have a working data collection and dissemination system. And on top of that, there has to be some people in at the decision making level who should use the data which has been collected to make relevant decisions. And if data is being collected from the system but is not being used to make decisions, then it demotivates people who are actually collecting that data at the very source, and in this case, which is health facilities. So there are all these discussions which are happening. We may not have answers to all of them, but it's always good to discuss and debate on what is happening in your own countries compared to other countries, so that we can try to find some sort of, even if they're not fully developed solutions, but at least you may go away with some pointers in your head as to what can work. you know so moving on, the other discussion where there were a lot of responses was, how do you as a health professional, or some people who are not entirely in health, contribute to the health system? And it is very critical for you to understand your own role, your own position in the system, because you are working in this system, and every day you go to work, every day you spend 8, 9, 10 hours in your offices or wherever, in sometimes you spend it in a field, sometimes you are interacting with consumers, patients. So it's very important to know how are you contributing to this entire system, which is a very big system. Health system is a very complicated multi-stakeholder system, and you yourself are, I don't want to say insignificant, but each of us in our own capacity are a very small part of the system, but we are not insignificant. And that's the reason why we need to know, how do we contribute to the system, so that it makes our jobs easier, it makes us more motivated to go about it on a daily basis, so that we know that this is the difference that we are making in the society or in the system. And this discussion is really interesting to read, as everyone, you are talking about from your own perspective. So that was really interesting to read. I hope now all of you have seen these subgroups which we have created: Team Red and Team Blue. In my in the team that I'm mentoring, I don't want to say my team; it's everyone's team. I had put a comment about changing the name. So if any one of you have interesting names that you want to put for this team, please write them in the feed of this group, and then we will select the most appropriate name for Team Red. I don't know what Team Blue is doing, so Gilles, maybe you want to say something on what is happening in Team Blue.
I think Team Blue has just started to interact. I think the suggestion for a new name was raised during the meeting we had on Tuesday. I think somebody suggested the Avengers, but it has not been brought back on the discussion. So yes, still looking for a name, if another name is needed. But I think we will have a blue color, which is always nicer than the red. So as much as I understand, red may want to change. I think blue may want to keep it blue. I'm seeing that somebody, Maureen, I see your picture and I think you are red and blue. I don't know if it's on purpose that you brought those color in a kind of unified.
Yeah, right. I'm actually princely. Not Maureen.
Okay, sorry, princely.
Yeah.
Thank you.
Yeah, thank you.
He's representing both sides today. Okay, moving on.
That's true. Yeah.
Finally, this was the leaderboard when I saw it last. Maybe it has changed since then. I've not seen it, but the last time I saw it, probably 4 hours before this call, these were the first 6 positions, and I can tell you that it changes every couple of hours. So I really appreciate that everyone is taking this seriously. Everyone is going through the lessons, and I really appreciate that you're taking your time to understand the questions that have been posed to you in those discussions, voice your opinions and case studies, and responding to them in the best possible manner. Yeah, so really interesting things that are happening in this group. So really appreciate all your efforts, and really proud of this group. So let's begin. Sorry, before we begin this session, just for a couple of minutes, if anyone wants to talk about their own experience of going through these 2 modules, even if you have not gone through the entire 2 modules. If you want to share any specific thing, positive, negative, positive would be great. But if you are struggling with something where you really want us to make things easier, a couple of minutes if anyone wants to speak. You can just unmute your microphone and start speaking. It's okay. Okay, maybe no one wants to speak at this point. So let's move ahead, and before I hand it over to Gilles, let me just again go through some key points. So for this session, we are talking about supply chain governance. We will look at these concepts. There will be some questions for you, discussions. There will be some polls as well. If you want to ask a question, raise your hand. If it is not a Q&A session, so if you can raise your hand, and then we will allow you to speak, or you can also ask your questions in the chat. Okay, and like we said in the previous time, it may not be possible to answer all your questions. So if there are some questions which we have not answered, we will answer them in the Q&A forum that is there on the course. Okay. So with this, I hand it over to Gilles. Gilles, over to you with the first section.
Thank you, Sanjay. Good afternoon, good morning, good day. Good day is easier, I think, to everyone here on the platform today. It's nice to have you all, and really, I guess that I hope we'll have an interactive session. So really, if there are anything which are unclear, anything you want clarification on, please do not hesitate anytime. Either you raise your hand, or you can take the microphone directly. It's not like everybody's fighting for the microphone. So feel free to go for it anytime you feel you should. The objective of this classroom session right now is going to recognize and to work, to try to work on how public health supply chain are governed at country level. So in this course, and maybe outside of the course also before, you may often have heard people trying to compare public health supply chain with private sector practices. We hear a lot about private sector does it well, private sector does it like that. This is the way private sector is doing it. So it's very important to make sure that we understand why it is not always feasible to replicate the private sector approaches. It's easier to say, but in fact, private sector supply chains are very different than public health supply chain. And one key element is this element of governance. If you look at private sector supply chains, they are very often very clear on what is the governance structure, who is responsible and who is accountable for the product flow. While if you go and look at public health supply chain, and all those who are working in public health supply chain, in the public health context may have seen that lines of responsibilities and accountabilities are very unclear. And there is no clear accountability, particularly on supply chain. It's not always very clear to know who is in charge of the various components of the supply chain, and it often requires a complex coordination among stakeholders. So we will want really to recognize today the issue of accountability and how this accountability can affect the supply chain governance and the supply chain effectiveness. As Sanjay said, we're going to try to have some presentation about concepts. If you want to ask a question and provide details, there will be polls also. There will be space for verbal Q&A, question and answer if that requires. There will be also some polls, so will be where you will have the opportunity to ask a question. So one element of the governance is this element of centralized and decentralized responsibility, or centralized and decentralized system. So as we've said, public health supply chain are complex. There are several programs, several products, several stakeholders. Sometimes you have different range of products, like program products. You may have also essential medicines. You have a variety of products and programs. You may have programs also which are handled by UNICEF or other stakeholders. So all those various stakeholders, all the products are interconnected in order to make sure that we reach the beneficiaries in the best possible manner. However, it is always needed to have a coordinated approach. And there is a central stakeholder who is managing the entire supply chain. In most cases, when you look at public health supply chain, the authority, the overall authority, the final responsibility and the accountability over the supply chain lies with the Ministry of Health. The Ministry of Health will either manage directly the supply chain or through a dedicated organization. It can be a central medical store, or it can be a logistics management unit. It will all depend on also the way it is organized in terms of central management and decentralized management of the health system in the country. For instance, if you look at some country, like if we take the example of Uganda, for instance, in Uganda, you have a central medical store, which is in charge of organizing, ordering, and dispatching the drugs throughout the country. So for instance, maybe we have Joshua with us. I don't know if you're here today, Joshua. No, I don't see Joshua here. So Joshua, maybe it's something we can discuss with him when we go back on the poll, on the hive, to see what is, how it is organized. You may have other countries where there is a more decentralized approach. Okay, so if you have a central authority, a national or federal authority which can take decision, this is a centralized system. On the other side, if you have a decentralized system, it's when the decision can be delegated to a lower level state, country, or province. I'd like to come back just at this stage on one very specific question, one point that Romeo has raised at the beginning of the course about when is it centralized, or when is it downstream and when is it upstream? Because it's the same kind of things for centralized and decentralized. It's a question of point of view. So you may have a health system which is centralized at a country or at a county or at a state level. So we'll see that for this particular unit, It is a centralized system, but it's not a nationally centralized system. And it's the same thing with the upstream, downstream. It really depends on where you look. You know, it's if you are at the middle, at the national level, you may consider that everything which is before the national level is upstream, while everything which is after the national level is downstream. But if your point of view, if your perspective is from the state or the province level, you will consider that everything before the province is upstream and everything after the province is downstream. So basically, you have to understand that depending from the point of view where you judge or you evaluate your system, you may consider that it's centralized or decentralized. It's very important because all the decisions, all your planning, all your design of your supply chain will depend exactly on that. So most of the time, when the health is under the responsibility of the health system is under the responsibility of the MOH, this is when there is a national level centralized health system. Okay. Yeah. Before we move to and on your, there's a poll now that we're going to ask about your own system. You know, how would you consider at a national level? At a national level in your country, would you consider that your system is centralized or decentralized? Is there a central responsibility for your health system? Please answer the poll. While we're answering the poll, is there any comment, specific comment that someone would like to make? Please raise your hand if you want to make a comment on this.
Yeah, I wish to say that from what we are seeing on the screen as we'll be voting, the system in Cameroon is a kind of practiced on both ends of the question posed. Is a kind of central decentralized structure where the Ministry of Health is responsible for policy making and other adjustments made throughout the whole system. And it's a kind of pyramidal kind of system where you have the central body, you have the intermediate, and you have the peripheral, whereby at the level of the intermediary, you have stakeholders like the regional funds for health, whereby they work hand in gloves with the regional and district hospitals for drug service supplies and other activities. Then on the peripheral, at the peripheral levels, you have the district hospitals and other small health centers who are also working hand in glove with them. And you will also come to understand that in as much as the central level is concerned with policy making, the central, the body which is responsible for drug supply services to all of these hospitals and health units in the country is called Sename. And Sename is the body which is responsible for supply of every drug commodity throughout the country. So in Cameroon, you have that kind of central decentralized structure, which is occurring back in our country. Thank you.
Thank you, Princely. Thank you very much. And yeah, we'll hear that in fact, most of the countries it's not always, you know, black and white situation. There is a lot of gray area. And so it's interesting to hear what you say. Thank you very much. We've seen that from the poll results. Basically, it's a 70-30% result. So 70% of the participants are from places where the health system is centralized at the country level, and 30% are more seeing it as a decentralized view. So thank you for this. We've seen that we have a hand which has been raised here from Tadele. Tadele, please take the mic and we hear from you. Please, Tadele.
Hello, everyone. Can you hear me, please?
Very well, loud and clear. Please go ahead.
Yeah, I'm Tadele from Ethiopia, just to reflect on the health supply chain system in our country. There is in central level agency which is responsible to procure and store and distribute health commodities to the lower level, to the lower stream. This agency is, established with the proclamation at the federal level, and it has regional hubs. So it seems like a centralized system, and any product procured from abroad or in the local manufacturers will be stored at the central IPSA level. The name of the agency is Ethiopian Pharmaceutical Supply Agency. So the procured commodities are stored at the central level, as well as it will be distributed to the hubs and then to the health facilities. So the system is integrated logistics pharmaceutical system, which is called IPLS. So health commodities are integrated and then distributed to from central IPSA to IPSA hubs and then to health facilities. So this is the way that is being managed in our country.
Thank you.
Thank you. Over to you.
Thank you. Thank you very much for this comment. It's really rich to hear from everyone. And indeed, we have cases like Kenya,
Nigeria as well. Oh, sorry.
Yeah, sorry.
Sorry, you're talking about centralized. Please go on.
No, yeah, I mean, those are mixed. So yeah, Kenya, Ethiopia, we have Sudan. I mean, we've had some comment also here, about from Wanjeru, who is mentioning that Kenya is like that. Also from Romeo, that there is an hybrid scenario in Salvador. So it's very often this element. Although we also have some decentralized systems, like for instance, Nigeria or India, where the states, local states have a lot of power and decision making on the procurement, the kind of medicines they will use, so a variety of elements that they take decision on. And then you have much more centralized element, as we said, we mentioned Uganda a bit earlier, where you have a central medical store who is receiving all the budget for procurement of medicines, and then who is supplying the quantities. They even decide on the quantities that they are going to ship to each of the facilities. So really, there is a mix of options, and this also bring back the idea, as you can see here on the element about accountability and responsibility. So we have a variety of stakeholders, a variety of process, supply chain process, but also organizational process, which are showing that in fact there are a variety of accountabilities and responsibilities which can be spread over various stakeholders. They can be national stakeholders and they can be private sector stakeholders. If we compare to the case studies that you may or you should have looked at during the course, you may have studied the Coca-Cola example, where in the Coca-Cola example, you have one organization with one set of processes who is in charge from A to Z, from the sourcing of the raw material, the production of the assembly of the product, and then the shipping of the product to the entire world, in fact. So this is really an example where we often dream, of course, of having medicines available, like we have a Coca-Cola bottle available everywhere at the end, at the last mile. But we also know that the organization, the way it is structured, the accountability is not the same, and the responsibilities are not the same. So there is a variety of stakeholders. And again, we can see sometimes that finance are going to be managed and overseen by a specific department in the Ministry of Health or even in the government. Sometimes it has to respond to finance Ministry of Finance. So there may be also interaction between various ministries. Human resources may be managed by public service commissions. Customer service may be managed by a different division in the Ministry of Health. the central medical store or national supply agencies may be also in charge of procuring, buying and distributing medical products. So all this is making a structure very, very complicated. Now, of course, we also have the issues of external stakeholders. We have UN agencies. We mentioned UNICEF a bit earlier, who can be running some specific program on vaccination or specific program on children, mother and child health. We can have the Global Fund, who is going to be focusing specifically on their program drugs. The three diseases, or four now with COVID-19. I think they took responsibility over that in several countries. So they are in charge of malaria, AIDS, HIV/AIDS, and malaria, HIV/AIDS, and
tuberculosis.
Thank you, tuberculosis. Thank you, Sanjay. So they have those responsibility on those specific. So all this is creating several responsibilities, several accountability, and several systems in an organization. So of course, if you compare with Coca-Cola, Coca-Cola doesn't have all those issues. They don't have all those stakeholders to come and tell Coca-Cola how they should run their bottle and their can. So that makes a big difference in terms of how this is being managed. You also have agencies, international donors. All this is making it very, very complicated. So now I think we were taking to another question, and it's about knowing and understanding, this stakeholder mapping, this map of all the stakeholders who are influencing your country's health supply chain. Anyone want to comment about that, about those multiple stakeholders that are influencing your health supply chain? Please feel free to speak and comment. And if you want to make some specific comment, I mean, it can be also some, I would say, perception about their importance. I mean, are they too important? Do they play too much of an important role? Are they too influencing or not enough influencing? That may be also something you want to comment on from your own experience. Okay. I think the next one is a poll, so maybe no.
Okay. Yeah, sorry, I have to unmute myself. I was saying Tedele wants to speak. Tedele, please go on. You can speak. You had raised your hand.
I didn't see, sorry. Please, Tedele.
Okay, thank you very much. I think if I'm clear, just the question is the one who are influencing the country's health supply chain or the donors specifically?
I think it's about everyone. It's about everyone who can have an influence on the supply chain. Donors can influence. So please, feel free to.
I think we can categorize it into two. The one who are positively influencing the supply chain performance of the country. So the donors, which are really supporting in financing, just funding, and donors who are supporting to strengthen the health supply chain system are positively influencing to have a better health supply chain system. So in Ethiopia, really there are so many donors, especially that are supporting the health supply chain system by just directly supporting the finance to procure those commodities, or just to support the system like the reporting and data management system, the distribution system, the technical strengthening the APLS implementation system. So we do have so many donors, and I think they are really supporting the system. And we have also other stakeholders like, the shipping agency, the Ethiopian Airlines, and there is also Ethiopian Food and Drug Authority from the regulatory perspective, and really the National Bank has great influence in the system, especially just regarding availing the hard currency to procure the products, and also, you know, we do have different stakeholders in the country, which has directly influence on the health supply chain system. So to make it effective, there is the one that I previously mentioned, the agency, the Central Medical Store, which is called IPSA, uh, is, you know, managed by mainly by board. So many of the higher officials from the National Bank, whatever, the Ethiopian Shipping Agency, Ethiopian Airlines are part of it. So they are part of the solution for the challenges that are related with the health supply chain system. And also among the donors, really the country is closely working with USAID, Global Fund, whatever donors, so that they are technically supporting the system. Thank you. Over to you.
Thank you. Thank you very much, Vadele, for this exhaustive description. I hope that maybe, you know, in the group discussion you can have on the Hive, it would be interesting to try maybe to develop a kind of stakeholder list, because that's also interesting to understand what we work with, but to describe what we could call a complex system. I think, Barbara, you wanted to intervene, please, Barbara.
Yes, in Haiti, we have three main donors. They are USAID, UNFPA, and Global Fund. But we are part, all the partners are part of a committee, and the committee is led by the MOH. So although we have each donor is providing commodities to the country, but they have to do that with the MOH. The MOH still have the lead, and they are working together to have one national supply chain system. And we have not, we are not there yet, but we are working to do that. But they cannot do anything without MOH. So this is the way it's working in Haiti. The health supply chain system is working in Haiti.
Thank you. Thank you very much, Barbara. From my experience, what you've described is probably the most important, but also sometimes the most challenging things to achieve, which is to have a real leadership from the MOH. You know, when you know that we have this say, you know, in France, where we say that sometimes the hand who gives is over the hand who receives. It's a way to say that when you give something to someone, you're trying to use this gift as an influence. So indeed, when a country like Haiti is trying to take decision and leadership on the choices they want to make for their health system and the health supply chain, they may be strongly influenced by donors who are giving funds and sometimes expecting to be able to be influencing decision at the table. So really this element is also
You're right.
It's also bringing us to leadership. How do we lead? How do we lead from above, from the front? Do we lead from behind? You know, what is the real leading strategy that the MOH is trying to take? It's really a very critical thing to make a change at the country level, this capacity of coordinating and making decisions. Sorry, Barbara, I spoke a bit too long. You wanted to intervene, please.
Yeah, this is what I was gonna say. Like what you just described, it's really true. So because they have the power, they are giving money. Sometimes they influence MOH. But what is good also, it's not, they will not do anything without MOH. So MOH is always part, although they influence MOH to take the decision, but it's always part of the process. They are always part of the process. Over.
Thank you very much. And really, I mean, it's a point that as you know, professional in the public health supply chain, we must always keep in mind that our role is to empower the national authorities in their leadership exercise. So thank you very much. Thank you, everyone. There is one stakeholder that we have not mentioned that much so far, but which is also, of course, critical, and those are the pharmaceutical manufacturers. So those who are building up, making the product. So if you look at how would you consider them? Do you consider that the pharmaceutical manufacturers are part of your supply chain system, an interesting part, or they are outside of the country's health supply chain? What is your point of view on this?
Yeah, and all of you who are saying yes to this question, there is a follow-up question as well, that why do you consider them as an intrinsic part of a supply chain? And if you have a valid reason, then do you think that when the central medical store they take strategic decisions about when to supply what kind of products, are those manufacturers duly consulted before making those decisions? Because if your stakeholders are not consulted before making those critical decisions, then unfortunately they are not really part of your system. So that's what to think about while you answer this question. And again, if people you are not speaking, please mute your microphones, because sometimes there is an echo which comes from background. So this is the first break. Again, if you have any questions at this point about centralization, decentralizations, stakeholders, please you can ask. You can also make any comment if you want at this stage. We'll just stop for a few seconds to see if anyone is interested. Otherwise, we'll go to the next section, which is this my turn now? Yes, this is my turn now. So Gilles, thank you so much. Again, if there are any other comments, questions to Gilles about overall governance, responsibilities, we hope that you understood what we're trying to say about governance and responsibilities in supply chain at the beginning of this course. Because when we talk about procedural questions like what to supply, when to supply, who will get the supply, how much supply will they get, all these questions become secondary if the governance is not right. And that's when we see a lot of problems in those procedural issues. Yeah. So I will just end this poll now. I think there are no comments or question at this stage. And so I will begin the next section. Okay, just 1 second. Yeah.
Can you comment the results on the poll also, Sanjay, before we move?
Okay, 1 second.
You want to comment or?
Yeah, so most people, about 80%, they think they are an intrinsic part of the health supply chain. Again, I asked the same question to all of you who have said yes. Do you know that those suppliers are consulted often when the ministry or the central medical stores are taking critical decisions about commodity supply, and some places you call commodity security as well, when you're trying to secure commodities for your country's citizens. And a very typical example is during COVID. When there was an acute shortage of PPE kits, there were acute shortages of vaccine right now in India. And one of the reasons there is acute shortages of vaccine in India, because the suppliers were not really consulted, and the reason, or what they were not consulted of, was their production cycles. When should the government order so that the vaccines are available at a certain time? Those things were not consulted and which is what is coming out right now. And these are very these things we often see in supply chain, in regular supply chain, that there is a shortage of an antibiotic, there is a shortage of syringes, for example, and these things happen. And one of the key reasons that happens is because the suppliers were not really consulted of their production cycles, of demand, how much can they manage, and so on and so forth. So if you think that suppliers are part of a supply chain, then they should also be consulted when making critical decisions. So that's what we're trying to say in this point. So moving on, we talk a bit more about governance, because now from the responsibilities and decentralized or centralized systems, we also want to see that uh, who is managing and what is being managed. So when we talk about governance, 5 points are really important, which ensures that supply chain is running smoothly and there is a continuous supply of products. And those 5 points are: one, we already discussed, which is the system or the structure of health, whether it is centralized or decentralized, who makes the decisions, how is those decisions implemented. So that's what we already talked about. Second point is, what is the legal structure between the central medical stores or whatever equivalent authority that you have, excuse me, or whatever equivalent authority you have in the country, with the federal ministry and subnational authority. Now, for example, in Ethiopia, we know that there is a federal ministry of health, there is a supply organization named IPSA, then there are different regions. Every regions, they have their regional health bureaus. Then there is something called a Voreda, which is like a district or a sub-district. They have their own Voreda health offices, and everyone has some sort of responsibilities along the value chain. Now the question is, what is the legal structure between all these bodies? Because it really affects the flow of products, it really affects the flow of information, and it affects flow of money. If those structures are not clear between these different organizations, and even between the CMS and the FDA or the bank, or if you have a national logistics company which is supporting the purchasing organization, so what are those legal structures? Are they partners? Are they under the same umbrella of the Ministry of Health, or they just have an MOU, or it's just ad hoc basis? So those legal structures are very important when we talk about governance. Third is, what are the policies on human resource management, uh, uh, financial management, and public procurement? Sorry, one second. Yeah, because for any supply chain organization, these 3 points are critical. Human resource, because of obvious reasons, no organization can work without a regular supply of people, and not just people, but skilled people who know their jobs, who are paid well, with the right environment created, work environment created in the organization, with the right culture. And if that organization is not able to manage all these points, then there is an issue. And we have seen it in several countries as well. Second point being financial management. Is that organization does that organization able to manage their own finances? Do they have to do they take decisions by themselves, or they have to go to another organization within, let's say, a Ministry of Finance or any other organization? Same with procurement decisions. Now, health is a public subject, and when ministry procures products for citizens, it comes under the purview of public procurement. And we all know that public procurement is always been like a controversial child in any country, and because it has a lot of money involved. So who manages that? Now in many countries, the supply organization will have full powers regarding what to buy, from where to buy, the entire process. So they have all the powers. And in some countries, they have to go through a third organization as well. Okay, something like a public procurement authority or another wing or a department within Ministry of Finance or something else. And sometimes these create hindrances in smooth supply chain or procurement processes as well. So it's very important to understand who governs and manages these three important facets of organizational management. Fourth, presence of donor ecosystem, and we discussed it briefly in the previous section, because for any or not any country, but most of the low and middle income countries, wherever most of us we are sitting, we are in low and middle income countries, except probably Gilles. But anyways, jokes apart, we have a lot of dependency on the donors. Yeah, donors, they are funding product requirements. Donors are funding supply chain processes. Donors are funding system strengthening processes. And if I have to ask a very crude question, very hard question, will your supply chains survive tomorrow if all the donors pull out? If the answer to that question is yes, then your country is doing really well. But I know for a fact that probably 99% of you will say no. If the donors pull out today, the supply chains will collapse because of the obvious reasons we know. And then finally, one of the key points is the development of the private commercial sector. How developed is the commercial sector in your country? Commercial sector can be local manufacturers. Commercial sector can be logistics providers, shipping companies, and probably, let's say, some others like private banks, uh, human resource management companies. So there are a lot of organizations which can play a role in this. And these 5 points what we have identified, they make a difference when we talk about governance in supply chain. So when we talk about governance in supply chain, it's not just about picking boxes and sending them to another location. It's not just that. We're talking about multi-million dollars of operation annually, where the authority also have to manage public perception and
One,
sales.
sorry, one element that I would just like to add about the private sector is the importance of private pharmacies. Yeah. And if you look at, you are referring to some countries like France or let's say, European countries where in fact the health system has developed very well up to the last mile, where people can very easily access medicines at the last mile. And it's mostly through the private sector, because you have private for-profit pharmacies which are available, everywhere, even in the smallest villages, so that even those places can access, medicines, and if they don't have the medicine in stock, there is all a private system of ordering and supplying. So the private sector has indeed played a significant role in this key element, which is the last mile delivery. And we all know that in a lot of countries, in a lot of LMIS countries, the LMIC, countries, one of the key issues is this last mile access. It's very costly, very expensive, and that's why donors are usually struggling to pay for it. And it's not a profitable business. So those 5 points that were shown by Sanjay are very important to have in mind when you will have to design a system or enhance an existing system, because all those points are strongly influencing the decisions that needs to be made in terms of processes, ways of working, resources that needs to be allocated to the system.
And this brings to another discussion point, for everyone. In your country, wherever you are, do you think that your national supply chain organization, or if there are more than one organization in your country, they have the full authority on all these points that we mentioned? Like, public finance. Okay, I think there is an issue with my video. Let me just stop it for a moment. Like public finance, procurement, HR, do you think they have the full authority on these aspects of management, or they are dependent on another organization in the country? You can speak. You can also put your comments in the chat. Uh, I'll just pause for about 10 seconds, and then if no one wants to speak, I'll go to the next section.
I hope everyone can hear me.
Yes, yes, please.
Okay, I'm from Wilson from Cameroon. I just want to say that on papers it's true for Cameroon, but in reality it is not. As corruption and bribery has taken over, the central body that is responsible for all these things would have been Sename. But unfortunately, the Ministry of Public Health and other hidden powers bring negative influences from behind and cause the work that Sename is expected to do not to be fully done. And talking about public finances, oh no, they are dependent on the Ministry of Finance for the financing, and so they don't run the finance themselves. Procurement, they would have been the ones directly involved, but unfortunately, like I said, the Ministry of Public Health and others, other powers that are hidden, not named, come from behind to influence the procurement, so that at times what the customer, that is the patient, finally has as the pharmaceuticals. Maybe it can be of poor quality, or in the quantities might not be sufficient, but yet the finance that has been spent to acquire that is much. And talking about human resources, a lot of bribery has set in so that they manage the human resources based not on technical know-how, but yet on the influences that come from other governing bodies. Aside that, so Sename would have directly been involved in the management of all this, but unfortunately, it is so true on papers, but in reality, it is not so. Thank you.
Thank you for Wilson Ghani. Just a quick point. I don't know if you're sitting alone or with other your friends, but probably there is some issue where there's a lot of echo which comes when you speak. So maybe I try to use a microphone or a headset so that we can hear you clearly, because we only heard part of it, and then part of it was not really audible because of the background echo. Yeah, but more or less I understood. Okay, there's still
Oh, sorry,
echo coming.
we are actually together. Oh, sorry, I didn't know you were still talking. I thought you had finished talking. Sorry about that. But we are almost all of us together, apart from Mr. Gemo, who is not here. We decided that each time we have classes, we come together as one group so that we can share ideas as Cameroonians and see how we can share to the high.
Then I would suggest that probably in the next classroom, if all of you can sit together, so that because of different devices, there is echo coming. But anyways, we can figure that out later. Let's move on to the next section. And sorry, just before that, let me conclude this part about the governance. The reason why we want to we're putting so much of emphasis on governance and who manages what, if they have full control, full authority or not, is because when you compare uh, public sector with the commercial sector, in the commercial sector, even if there are more than one organization coming together and looking after the supply chain, they have one common motive, and their common motive is to make money, is to increase their bottom line. And that's why most partnerships, they gel very well because everyone is there for business. Everyone is there to make money eventually. But that is not really the case in the public sector. Yeah, we are not in the business of making money. We're in the business of service. We're in the business of alleviating pain, yeah, and suffering. So then the question begs, what is the common factor amongst all these different organizations in public sector that may bind or binds you know them to come together for this supply chain operation? What is the common factor within all these organizations? So think about it. If you find an answer, please put it on the chat. And if you want to speak very quickly, if you have figured it out already, then you have the space. Please unmute yourself. You can talk about it. What is the common factor that binds all the different entities in the health system or in health supply chain?
Yes, my name is Kenfree Matuma from Kenya.
Please.
I think one common factor about the different players in the public sector are improving certain agreed upon indicators in health. That is like decreasing the burden of disease, for example, having particular diseases eliminated, or generally patient. It's about the patient and the end user of the products. And I also believe it's about having, let's say, customer satisfaction in the form of having the agreed indicators reach to a level that is acceptable for all the players. That is my take.
You took a very good point, Kenfree. You talked about customer satisfaction, and here I would ask everyone, who is the customer? And I ask this in all my classrooms, wherever I am, and I always get different answers. So I ask you as well, who is the customer here for a supply chain organization? Yeah, Chamini says patient. Okay, Rahul says citizens. Okay. Okay, you figure it out, and then I'll talk about it again at the end as well. Okay. Moving on. Okay, maybe Princely, you want to speak quickly?
Yes. In this situation, customers differ as you cut across the supply chain, because you won't say that a patient can be somebody who is receiving a supply in a hospital to give to another person. A patient is a customer, and equally a hospital is also a customer who delivers these products to the patient who is in need of it. Because normally they receive it from the central supply system, who is a main supplier to every part of the country. They are customers. When they receive this product, they now give it to the other customers down the stream who receive the product, the end products, and they are satisfied with what they receive. So customers differ across the chain. Thank you.
Tedele, you want to speak, please?
Yes, as my friend said, the customer can be different in the different parts of the chain. So an agency which is procuring from the manufacturer can be a customer, and a wholesaler who is distributing to the downstream can be a customer. So a customer can be different part of or a different entity in the chain. So even a manufacturer can be a customer for the raw material supplier. So across the chain there are different customers, but in the health supply chain system, the patient customer will be a patient who is taking the medications.
Thank you, Tadili. Rahul, you raised your hand. Please quickly, please raise your point.
Yeah, I lowered the same as well. Thank you, Sanjay, because I was pretty much covering the same point that Tadile was saying.
Okay.
I think he has already covered it quite well, so I'll not speak further on it.
Okay. So I'll go back to my previous point. Actually, now that some of you have talked about that in supply chain, customers can be different. So I go back to the point that Kenfrey raised, that one of the motivations for different organizations would be to satisfy the customer's requirement. Now you say that customers can be different. So whose requirements are we actually satisfying? That's the key question to think about. Just think about it. We don't need to debate it today. Just think about it. And that's why we say that health supply chains in the public sector are very complex. They are very convoluted sometimes. And maybe, I don't know if you have seen something called a spaghetti diagram. If not, we will post it. Andrea, please note, we need to post the spaghetti diagram on the Hive, so that people see how sometimes supply chains can be very complicated and complex.
Sure.
Yeah. So moving on, let's go to the last section of this session, which is about flow of products, money, and information. So now that we looked about how is health organized in our countries, whether it is centralized or decentralized, supply chain may be centralized and decentralized, who's managing the supply chain, which are the different stakeholders. Now we come to the procedural part of supply chain, and we talk about, although we're still talking about overall governance, we're still not going into supply chain functions. We are looking at it at a higher level. So we've begun this week and this session at a higher level. We're not going into which products do we want to supply, how much of those products we want, where are we sourcing them from, and where are we sending it to. So we're not talking about detailed supply chain functions. We're looking at it at a higher level, that who's managing, who are the stakeholders, and how does the product flow in the country, how is the money flowing in the country, and the information as well. Okay, so we'll look at these 3 points one by one. And as you see on the screen, governance of supply chain and how various stakeholders gets involved, it influences these 3 aspects: that how the products are going from one tier to the other, how the money is flowing from one place to the other, and information as well. And if you see this slide here, we are just showing very simple scenario where supply chain is managed by one organization which has an office and a central warehouse. They are procuring it from different suppliers, and then it is consolidated at a central warehouse, from where it goes to either directly to the hospitals or health centers, or probably through a regional warehouse or a regional distribution center. That's a very simple scenario. The other scenario of flow of products can be that there is no central warehouse, there is no central supply chain organization. Every province or every state or every county, they have their own logistics management units or supply chain units, and they have their own warehouses. Every state, province, county, they are contracting the suppliers directly, and the suppliers are then directly sending it to their warehouses, and then from those warehouses, maybe even from there, they are going to another consolidation center, from where it goes to the health facilities and the hospitals, or it can directly flow from that particular state warehouse or a county warehouse to the hospitals and health centers. So it can be different. And then you add different programs to it, it becomes even more complex, because sometimes the Ministry of Health or the central medical stores, they are managing what we predominantly call essential medicines, right? And then there are donors who are managing programs. So Like we said before, Global Fund is managing HIV, TB, malaria, and now COVID. UNICEF is probably managing immunization products like vaccines and maybe some mother and child health products. UNFPA is managing, supplying, and managing family planning products. Then there can be a couple of other partners, supplier, or donors who are probably managing a couple of other programs. Like now, in some countries, there is a cancer program which is managed through USAID funds by CHAI, Clinton Health Access. There can be DNDI, Drugs for Neglected Diseases Initiative, who's managing those small those products which are required for rare diseases like visceral leishmaniasis and similar diseases. And when you try to plot them together on a supply map or a try to map the flow, you see arrows going different places. And sometimes these donors and partners, they will consolidate their products at a single warehouse, just like it happens in KEMSA, or they may not want to do it. For example, in DRC, in Congo, Democratic Republic of Congo, donors, they have their own operations as well. They each donor, they have their, even in Bangladesh as well, different donors have different agencies working for them, buying their products, consolidating their products, and then sending it to the same health facility using different distribution channels. It gets very complex after a point in time when there are different stakeholders involved. So there is an exercise which will come at the end of module 2, or an assignment rather, where we will ask you to draw out the flow of product, money, and information for your own country. So this is just a precursor to that, so that eventually we see how simple or easy supply chain systems are in your country. So this is for the flow of products. One more thing that we should talk about here is integration. We have been talking about supply chain integration in health for decades now. There are several countries who have taken a lot of steps in towards going towards integration, and some countries have succeeded in that in those steps as well. Like we talked about Uganda, there is Malawi now trying to do integration in their country. I think Kenya was, not integrated before, then they were integrated, but then their administrative structures became devolved, and that's when it became a bit more challenging for Kenya as well. Then there is Ethiopia. Again, they were not integrated before. Now they're integrated since PFSA came into being. So there are different countries at different levels of integration in their supply chain as well. So at this point, probably let me ask you a question, that how many tiers, now when I say tiers, is wherever the products are stored even for 10 minutes, for example. So how many tiers does product go through to reach the consumer or the patient in your country? You can type it out in the chat box, or you can speak as well, and you can also name those tiers wherever the product goes or stored before it is actually dispensed by a pharmacist. I will just pause for 10 seconds. Okay, Romeo is saying 3 to 4 tiers. Okay, let me move ahead, and if you figure out, and then you can put it on the chat. Next up is flow of money, and which is one of the most important point in the supply chain, because if the countries don't have money, they won't be able to purchase those products or even supply those products from one place to the other. So money is really important. But the important question is, who pays for those products and how those products are going from one place to the other? There are different schemes that the countries have in in different countries. There are different schemes, different financing models. I mean, in health, we call it health financing. Here we're calling it supply chain financing. There are many countries, and mostly in Africa, where the products are paid for by the patients. For example, in Kenya, in Ethiopia, in Sudan, in several countries, they're using something called a drug revolving fund. But even in that case, the patient is paying for those products, except if they are the program products, which are already paid for by the donors. So then the patients don't have to pay. But in majority of cases, except those program products, the patients are actually paying for those products, even if they are below the market rates. Yeah. And then that money is consolidated at different levels, and then that money is used again to purchase the products and supply them through these different tiers that you're talking about until it reaches the patients again. And as I see the chat, a majority of you are saying 3 to 4 tiers. I think in most countries in Africa, that would be the actual scenario. But if you look and Kenfrey is saying it may be 5 tiers as well if it is donor funded. But if you look at a large country like India, for example, there may be up to 5 tiers as well in some cases, and it also varies from product to product. Some product may have as low as 2 tiers as well. I mean, for example, in India, I know there are some products which directly goes from the manufacturer to the hospital, and then that's probably just 1 tier. And then there are some products which go from the federal level, one warehouse, to state level, one warehouse, then to district, then to sub district, and then to the health facility. So there can be 5 tiers as well in those cases. So going back to the financing question or the financing discussion, like I said, one is that patients are paying, and those funds are consolidated and then being pooled again and reused to purchase and supply those products back to patients. The other arrangement is where the government, they pay for the products using the taxes that they have collected from the citizens, or if they have any other mechanism. Some examples of those countries are: one, India. In India, essential medicines program in most states are funded by the government. It's a different story that it's still not being used so much by the citizens in the public sector, because in India, private sector is big. So that's why public sector is, I would say, not that much in use in the urban areas. But if you go to the rural areas or semi-urban areas, public sector is free of cost for patients to access. Then there are other countries, I believe in Uganda as well, it is paid for. Patients are given it for free. And then there are some other countries like I think Mauritius, where it is free. Patients may have to pay some sort of user fee or a one-time payment, which is very low. And then all the services and the products are free of cost. Then there is a mixed variant as well, where there is also insurance. Insurance is not very prevalent in Africa. I don't know about South America. I've not studied South American systems. So maybe Romeo or Barbara, you will have to help us understand the coverage of insurance in South America. But in Africa, insurance is not that prevalent. Yes, there are some countries where there are some insurance schemes that either the government has come up with or the private sector has come up with. But in Africa, in total, the coverage of insurance is quite low. But then it's still an option where the insurance pays for the products consumed by inpatients or sometimes for outpatients as well. In India, for example, there are several insurance schemes which works in tandem with the government funded schemes of free medicines as well. And then finally, donors are the third medium who actually pay for the product. They don't only pay for the product, but they also pay for the logistics of those products as well. So Prinsley is saying insurance in Africa is a challenge and it does not even exist in several of the countries, and you're quite right. So that is probably one area which the African leaders really need to focus on how to bring insurance providers to the country first of all, or how to probably grow in homegrown insurance providers in the countries themselves. So these are some of the overview of who pays for those products. In one of the later lessons that you will see, there will be a bit more about drug revolving funds. There will be a bit more about insurances, so you can read them there. Now, going to a quick poll to understand, from each of you as to who pays for the commodities in your country. So I'm launching the poll right now. So there is, okay. So the poll is now on your screen, and while you're taking this poll, Audo is saying in Nigeria there is an NHIS, in Kenya as well there is an NHIS, but the question is, what is the coverage of that insurance? Having an insurance scheme is one thing, but the coverage of insurance is more important. Does it cover the entire population? Does it cover only 2% of the population? How much does it cover? Which diseases are covered? Which products are covered? Those are also very important questions to understand when we talk about insurances. Yeah. So maybe when you go back, look at all the insurance providers rather, or insurance schemes which are prevalent in your country, and then try to read about how many people or how many citizens are covered under those insurance. What is the per capita coverage in dollar value or in your own national currency value? What is the coverage that is being provided? What is the premium that is being paid by a user, or what is the premium that is being paid by the government? Sometimes the government is also paying a premium to the providers. And finally, which diseases and products are covered? So those are some important questions to understand and look at. So as the poll is going on, majority of you are saying that the patient pays for the commodities except for the program drugs. Now, I'm a big fan of drug revolving fund. Trust me, I am. I've seen it very closely in different countries. But the question that I've always asked those administrators who are running those funds is, are the commodities affordable for the patient in your country? That's the same question I will ask you. So you are working in different hospitals, you're working in sometimes in central organizations, in UN, in technical agencies. Do you think patients in your country, and more importantly, patients in the rural areas, find the product that you are supplying affordable? If you say yes, I would be very happy. So these are the results of this poll. Most of you have said that the patient pays for the commodities except for the program drugs, and which is very true in majority of the countries. Yeah, and in Africa, I know for sure. South America, I'm sorry, I have not studied those structures in depth. In India, it's a mix. Donors' share is not that big when it is compared against the government share. But then in India, the private sector's share where the patient directly pays, not even the government is in the picture, is very big. So in India, the private sector, the patient out of pocket is very high. Then there is government, and then there is donors. Probably in Africa, in some countries, there is a donors sometimes very high, or government very high, and then private or out of pocket, or sometimes very high out of pocket and very minuscule government and donors. So it's a very wide mix in Africa. Now, finally, moving on to the last part of the equation, we talked about information. And when we talk about supply chains, information is key. Like you must have heard about this statement, is that what gets measured gets managed. But how do we measure something? We need data. So to measure anything, we need data, and to have the data, we need to collect that data from its source. And in supply chain, the data is actually coming from the health facilities or the hospitals. Now, if the people who are working in those facilities and hospitals are not collecting that data, then administrators sitting wherever they are would not be able to manage supply chains effectively. Yeah, so it's a key part of the equation. Without the right data, and I go back to one of the points made by Barbara in the discussions, that there is unavailability of consumption data in Haiti. And it's not just Haiti, Barbara, but there are so many countries where quantification is still done on distribution data, on supply data. And that's why we see a lot of stock out, or we see a lot of overstocking resulting in expiries, wastage, and then dumping of products. So it's a real challenge everywhere. And you see that although there has been significant investments made by donors in setting up LMIS and ELMIS systems lately, where we talk about now mobile data collections, we're talking about you know automatic data collections as well using barcoding. There are some places where it is being implemented, uh, but it is still, I don't think it is still enough in many countries. There are some countries where there are so many systems running in parallel. And one example is Nigeria. In Nigeria, I believe every other state, they have a different ELMIS running. The federal government may also have their own, or maybe there is a policy where the federal government is asking states to run a single set of ELMIS. But from what I've seen, different states, they have different LMIS systems in operation. And our friends from Nigeria, Audu and uh, Panchak is not here with us today. I don't think so. But Audu can tell us what kind of ELMIS is in the state where he's working, and if he has seen other ELMIS systems as well. And then finally, the other key point about data is this lack of accountability when it comes to collection, reporting, and the quality. And this is, I would say, this is the key point when it comes to about information systems. We can set up very robust information systems, dashboards and automated analysis and all, but those things won't work until the people who are sitting in the facilities and hospitals or regional offices or state offices, they don't report the right quality data in the right time. So the first thing has to happen is the culture of collecting and reporting data, and that there has to be right data. It cannot be wrong data. The data has to be about the amount of patients who are coming, what kind of uh, conditions those patients had, what products were supplied to those patients, and all this data has to be collated so that there can be some form of checks and balances, that if that this much amount of products has been dispensed, then these many number of patients should be there. There has to be some parity between the amount of drugs dispensed and the number of patients treated. They cannot be different, right? Because we all follow something called standard treatment guidelines. So the physicians and the pharmacist, they must not waver from those guidelines. That's why we need both types of data to sometimes triangulate as well, that okay, how many patients were there and how much how much of products has been dispensed, and based on that we can take those decisions of on how much to supply, when to supply, those decisions must be taken based on the right amount of data. And finally, this brings me to my last question for discussion. How is information managed in your country? This is the last part. And who manages ELMIS in your country? You can speak. You can also put it on chat. Let me see if something I've left. Yeah. So this is the last discussion for this session. We are about 5 minutes late, but it was good to hear from a lot of you, and I see a lot of points in the chat as well. And Audo is saying yes, there are different unique LMISs, but now he's learned that federal government is trying to resolve those things and trying to make one single standard LMIS across all states. Yeah, so that's good. Anyone wants to share LMIS example from their own country? Who manages that? Is it a paper-based LMIS? Is it an eLMIS? How is the data collected? And at this time, I would also like Gilles to chip in. I hope Gilles, you're still on the call. I've not bored you to death.
No, of course not. Of course not. Of course, clearly not. Thank you very much. Yeah, I mean those three elements of product flow, cash flow or money flow, financial flow, and information flow are really the three things to always keep in mind when we design or when we want to enhance a supply chain system, because they are the fundamentals, they are the three pillars of any system. So of course we need to make sure that they run smoothly. And yes, paper-based can work, but as you said at the beginning, it has worked for many years. Supply chain systems were designed with paperwork, but in the times when we are living now, where you have a pressure for timely responses, being able to access information in complex system, this number of stakeholders who are intervening, that needs collaboration and have access to similar information, it's very hard to achieve with a paper-based system. Yes. So, there is always this discussion about should we move to a full integrated system, or can we go on working? And there is no real evidence that a full integrated system works better than any other system, except that usually those who have not moved to a fully integrated system are not here anymore. So yes, it has worked for some times, but it doesn't work anymore now. And with the challenges, the environment we're in, we obviously need to move to a fully integrated system. So it is very important. Of course, this can take, and we'll speak about that later, warehouse management system, which, I have these things for warehouses. I'm sorry. I think warehouses are the heartbeat of any supply chain. If you get your warehouse right, you can get all your supply chain right. If your warehouse is wrong, you'll get it all wrong. And I think it's the same with system. If you get your warehouse management system right with the proper information, clean data into it, then you can get your entire logistic management information system right. If you don't get your warehouse management system right, it's very hard to get the right.
Gilles,
yes.
good folks in Zara clothing may challenge you on this.
Yes, maybe we can discuss. I'm sure you have counter evidence, of what I've just said. I'm sure you will.
No, but you're absolutely right. But one of the points that I would like to also put forward to everyone here is that eLMIS is not the solution to all the supply chain problems in your country. It's not. I've heard so many times people saying that, oh, if we have the eLMIS, our supply chain problem will be solved. But no, it's not true.
It doesn't work like that.
Another point here is that having a very well designed eLMIS system is not enough. Even if it is very nice, you have whoever the provider was, you have institutionalized in the central office. Let's say if you're in Ethiopia, it's in Addis. If we are in Nigeria, it is in Abuja. It is not enough, because that eLMIS has to be functional in the most remote corner of that supply chain as well. And like I said, the most important part of LMIS is the source from where the data is coming. ELMIS doesn't work if it is not capable of collecting that data from the source. And we know it's an issue because of internet coverage in majority of the countries that we are talking about. ELMIS doesn't work if there is no internet. Yes, there are some offline modules, we have heard about it, but then it's as good as paper-based data, because the data is coming to you 7 days late or a month late. It doesn't really matter. So it only works if you have very good internet across your country, and ELMIS works if it works at the source, not where the decisions are being taken. So keep that in mind. Okay. Uh, I'm just looking at some final chats. Yes, very nice. Very good. Okay. So then we move to a last Q&A and poll. So if there are any questions, comments, anything that is burning you want to speak out, this is the chance. Or then I will go to the last poll of the session before we close out. So if anything is a burning question or a burning comment or anything that you want to say, this is the time. Or otherwise, we will meet next week, same time on Thursday. Uh, you know, and before that, we will see each other on the Hive. Keep contributing, and keep learning, keep talking to each other. This is your space, we have created for you. Princely, you want to speak?
I just want to say that it was a very excellent and interactive class today. And I am sure everybody must have gathered up to 95% of the concepts involved in governance, information management system, and financing, in as much as drug service supply is concerned in their various countries. I also wish to say that I want to bring in a suggestion for our next class session. As I'm seeing Mr. Wilson putting on blue, who is a member in the team blue, I would like that those who are in the team blue should put on blue next week, and those who are in the team red should put on red next week, so that we'll get to know each other. We will not see only the names, but at least let us see our faces and appreciate our team classes so well, so that we'll know how we are going to interact. So that is just a suggestion. I don't know if our panelists will be able to give us that opportunity in our next class. Thank you very much.
That's a great suggestion. So Gilles, blue. So I'm actually representing team blue today. See, I'm wearing blue. So probably I have to find something red in my closet, because I don't think I have. But I'll try to find something red. And Gilles, I'm sure you will have something blue in your closet as well. And
yeah, blue is easier than red. I have to confess. But
and Andrea, you have to find something like Princely is wearing, both blue and red, because you are impartial.
We'll see about that.
Okay, so this is the last poll of this evening. Please rate today's session, and then if you again, the line is still open. If anyone wants to speak, this is the time. Or otherwise, we'll see each other on the Hive and then in the next session.
I just wish to join my brother to say that this is today has actually been wonderful. Today's lesson has caused me to start pondering over many things in my country, Cameroon, and thinking about the contribution that I can make to success, because there are a lot of things that actually are not moving the way it should have been, and hence the outcome on the patient is not usually the best, because talking about financing, I just was reflecting on what is happening within the CBC Health Services as part of the body that provides care to the patient. As we try to do that as an expression of Christian love, but yet we cannot, because the government who would have exempted us from some things like clearance charges and among many other things, so that the cost of the drug that we get can be affordable to the patient. They don't do that actually, and this makes it difficult for the CBC Health Services to actually provide the care in that manner. So we talk about providing it in a way that patients can be brought to Christ, And a patient where I, on daily basis, feels that at the pharmacy window will make you to say, what kind of services are you offering, just because of the cost of the care that you are offering to your patient. The drugs look so expensive. And the patient is like, what kind of thing are you telling me? So I just trust God that with the knowledge that we are gaining from here, I and my fellow colleagues will be able to think about something that can influence a change beginning from CBC Health Services. And why not Cameroon at large? Thank you for today's session. I think that was blessed.
Thank you, Anfor, and you're very right. You see, us as professionals, there is always as much as we can do. But one of the more important things for us is to know these things, because eventually we cannot make a difference until or unless we don't know those points or those facts. So for us as professionals, the first thing that we need to do is to know as much as we can about all these points which are pain points in each of your countries. And this course, these sessions, we're not saying that we will help you solve everything in your country, but what we are saying is that we will make you aware of these issues that we probably don't think about. We think that as a supply chain person or as a pharmacist, our job is either moving boxes or dispensing products to patients, but we forget that it's actually beyond that. So I believe through this course, you look at those issues in a bit more depth. You also look at these issues from other people's lenses, because we also have other countries represented in this group. And as you start to ponder over these points, probably in future you will find that you have some solutions to those issues as well. Yeah. Gilles, any final thoughts before we close?
Oh, I mean, thank you very much. I think it was indeed a very good session. Thank you for everyone who contributed, either speaking, with a video or not video, or through the chat. It was very, very good to hear from everyone. You said at the beginning sometimes that we can feel sometimes that our role are not significant. But yeah, I totally agree with what you just said, Sanjay. If we have a good perspective on the whole system, then we can change the system. We all can contribute to make significant change in the system. So really, that's what we hope this course will bring, this kind of spark that can generate further changes and transformation. And thank you all for participating. Thank you all for being here. It's a great pleasure to be together. Thank you.
With that, we close this session for tonight, for today. Rather, it's night for me, so I'm saying tonight. And we see you next week. And before that, let's keep in touch through the Hive. Keep doing your lessons. Team Red, keep doing your lessons, and we will see who wins the first learning week once we reconcile.
Sanjay, don't abuse your position, please. Team Blue. We are
Team Red.
All right. Good evening. Good day to everyone. Have a good weekend as well, and stay safe. Bye-bye.
Bye.
Thank you, everyone.
Bye. Thank you very much. Bye.
Bye.
Thank you. Bye.